as to, it's also a testament as to how important and how high the buzz is. All right, well, let's go ahead and dive in. What are health maintenance activities? And so in order to understand health maintenance activities, we have to go to the regs, right? And so what I'm going to do today is actually show you what the regs say. And so two different tasks were identified. The first says health maintenance activities are tasks that may be exempt from delegation. And so they require that an RN assessment be completed, stating that this task, for multiple reasons, although it does require a higher level of skill, it does not require delegation. Okay, there were some tasks specifically excluded from delegation, and those tasks were intermittent catheterization or the straight cath, and then anything dealing with insulin, right? And so personally, I know that one of the big reasons for all of the delegation and HMA talk is there's been a huge influx of elderly persons requiring insulin. And unfortunately, Medicare no longer is able to support those twice or 3 times daily home health visits. And so we're trying to figure out how can we keep these fragile individuals in a place of their choice while still supporting and helping them manage their diabetes. Okay, and then that reg actually took us to 225.4. I'm going to be doing a lot of switching back and forth just so you guys know. And then 225.4 says health maintenance activities are tasks that may be exempt based on the RN's assessment. And again, the goal is allowing that client to remain in the independent living environment. Independent living environment is simply the place that that person calls home. And so this particular reg goes into some of the tasks that can be considered HMAs, all right? Also some tasks that can be considered to be delegated. List a lot of tasks. I always say, just because you can do it does not mean that you should do it. There are some tasks on this list that as a registered nurse, I would not be comfortable allowing an unlicensed assistive personnel to do with or without delegation. All right, so of course, medication administration, if you are a owner, operator, manager in the long-term care industry, I advise that you become very familiar with the difference between administrations of medications and medication assistance. Most importantly, if you are in a dementia or Alzheimer's certified unit, you probably are administering medications, even if the person is putting it in their mouths themselves. Okay, I advise, we won't go into it here. You're welcome to come to one of my other webinars where we really dig into delegation and medications. Insulin can be delegated. Again, it cannot be considered an HMA. Routine administration of oxygen. So this is not saying, you know, I have to determine as an unlicensed caregiver, I have to determine when someone is short of breath or when their oxygen is low and make a decision to administer oxygen. That is not delegation. That is not an HMA, right? That requires assessment, which is outside of the scope of an unlicensed assistive personnel. A huge one has been these vents, you know, they're coming out with all kinds of cute little systems and sending residents, or at that time, their patients, even to their private homes with these different CPAPs and vents. And so as community owners or operators, we do have to look and dig deep to figure out what's appropriate for the assisted living community or the home, and what's appropriate for our caregivers to actually operate and perform. Hey, bowel and bladder programs, suppositories, enemas, you know, I was talking to, of course, her name's gonna slip my brain right now. It's not Connie. I was talking to one of the members that's with legislation, and they were telling me about, you know, talking to the Board of Nursing, and the Board of Nursing just kind of saying, hey, to date, we've just kind of let assisted living communities do what they're going to do. And so I believe that's why the stigma is coming up, and it's up to us to make sure that we are still not becoming unlicensed skilled facilities, right? There's a fine line between what we are allowing the caregivers to do and between that and becoming a skilled facility without a license. So I encourage you again to dig really deep and to make an assessment of what your residents actually need. If they need skilled care, let them go to a skilled community. All right, and then option J down here, or line J, this is pretty much where the Board of Nursing has rested. Those tasks that an RN may reasonably conclude as safe to exempt from delegation based on assessment consistent with 225.6 of this title. All right, so I'm gonna just go back to the PowerPoint to make sure I'm staying on task. If I'm staying on task, then I think we're going to now go to that specific, yep. Let's talk about 553.263. All right, so this is a big one, and I do not believe in reading word for word. What we're going to do is just kind of hit each point, and I will elaborate on what's being said. So a facility can allow an unlicensed assistive personnel or caregiver to perform health maintenance activities for residents without delegation. So again, this is saying that the RN is signing off saying this does not require any nurse supervision if the activity is performed for a person with a functional disability, as defined in 553.3 of this chapter. 553.3 kind of goes into, it can be mental, cognitive, it can be physical. So when you think about functional, what I think about is arthritis. You know, maybe I was changing my colostomy bag at home, but now because of the dexterity challenges I have, I'm unable to manipulate that bag, but I am of sound mind and I can direct a caregiver on how to do it correctly for me, okay? I'm gonna back up because I said I wanted to point out some keywords as we're reading through these regs in case there are owners and operators on to help you. I remember when I was first learning to look into the regulations, it was kind of confusing, and Janoyce, bless her heart, rest her soul, kind of helped me look at key terms. So one of the key terms you're gonna see is may. May is an option, right? You'll also see words like must. Must is not an option, and I'm gonna point those words out. Here we've got the facility may allow, meaning it's not a requirement, and then we also have only if. So if these requirements that we're going to go over are not in place, then the facility may not allow these HMAs to be performed. Okay, so we talked about the functional disability. Another requirement is that an RN acting on behalf of the facility conducts and documents an assessment that determines that the activity does not require delegation. And so keywords in here is assess and document, okay? You want to make sure that nurses coming in and actually documenting why it's safe and how all the requirements listed in this particular TAC are being met. What makes it an HMA, okay? A facility ensures and documents that all the conditions and requirements of subsection C of this section are met. Okay, and we're going to get down into subsection C. So when it talks about documenting that these requirements are met, I encourage you to have that RN documented, right? Because that RN in HMAs or delegation is going to be your saving grace, right? It's their clinical knowledge and expertise that's going to support these tasks being performed. All right, so then we get to 3A, the resident's legally authorized representative, that may be called an LAR, it may be called a CRA. Normally it's the person that writes you the check or makes the decision for that person. or other adult chosen by the resident is willing and able to direct the staff to perform this task, okay? And so here's where I get a little nervous when it comes to documenting that something can be an HMA as a nurse. Being in the industry, we have lots of difficulty when it comes to family or responsible parties responding and being present. And so you want to make sure, and as a nurse, I find it a bit difficult to ensure that we have a responsible adult outside of the resident themselves that is not only willing, but able to direct that task, right? And so it takes a lot of knowledge. It can be done, but you just make sure that that is in writing. Again, I would, if it were my community, I would have that person signing off saying that they are willing and able to direct the personal care staff. And how are they? Like, were they doing it at home prior to the resident moving to your community? And so a nurse has trained them. What makes them able to direct this care, right? When in regards to the resident themselves, all right, let me just clear this. If you have a resident in a certified Alzheimer's unit or even in an ALF, and you are documenting that this person is not oriented, they're not able to make their needs known, there is no way that you will be able to support documenting that that resident is able to direct their personal care, that they're able to direct the staff in performing those tasks. So just, it's funny, I'm always humored when an Alzheimer's unit manager calls and says, hey, can we do this as an HMA? He already had, yeah, no, if he's not oriented, he definitely cannot be directing. If it were my community, I would have that RN coming, and I'm sorry, let me back up. If it were my community and I am depending on the resident to direct the care, I would actually have an RN coming in at least every 6 months or change of condition. If the person goes to the hospital and comes back, I would have another assessment done and documented stating that that person remains competent and able to direct that care. Okay. Number 4, the activity addresses a condition that's stable and predictable. So big, very, very important words when it comes to delegation or HMA, stable and predictable, right? And so in the delegation world, which is my place of comfort, we talk a lot about insulin, right? And so if we're doing blood sugars, if somebody's coming in with a blood sugar, we know it's about 170 every morning and about 98 every evening. That's kind of stable and predictable. We kind of know that, you know, Mr. Johnny's blood sugar is going to range right in here, and this is how much insulin he's going to need, right? On the other hand, we get a referral and this person's blood sugar is 370, 151. It's not really stable. It's not really predictable. And for that reason, it probably should not be delegated, or for insulin, it cannot be an HMA anyway. But even if, let's say it's a colostomy. We had an incident at one of the communities we manage where there was a gentleman with a colostomy bag, and the colostomy was functioning fine, but the skin around it, like it was bad. The colostomy bag was exploding. The skin was breaking down. It wasn't stable or predictable, and therefore he was not appropriate to be there. Now, his wife was a nurse. She was there every day. She was definitely training and taking responsibility for the care of that colostomy. Perfect example of something that could be considered an HMA. Okay. The activity, number 5, the activity is performed for a resident who could perform the task on his own if it wasn't for the functional disability. So again, you know, I'm not a huge fan of it saying functional disability, because if you dig into the definition of functional disability, it actually does include cognitive. But if you have a cognitive disability that's preventing you from directing that HMA, then we're not in compliance with the other requirements. So don't read into that word functional disability, because if you read too deep in it, it sounds like pretty much anybody that's in, because I mean, yeah, I could do it if it wasn't for something being wrong with me, right? But that's definitely not what is to be gathered from functional disability. Again, maybe they have tremors, right? And so they can no longer empty their Foley catheter, things like that. That's a functional disability. They're of sound mind and they can direct that task. If it wasn't for those tremors, he would still be emptying that bag out himself. Okay. The RN conducting an assessment for purposes of subsection A1 of this section must perform an assessment considering all the relevant aspects of the resident's environment. And so basically what B1 is saying is that the RN must come in, and as a nurse, when we go in, we're going to take in who are the caregivers, what kind of experience do they have, what makes them qualified to be performing these tasks. And then the resident's health status, what comorbidities does this resident have? Again, if we're saying that they are alert and oriented ×3 and able to direct the care, then what type of care plan do we have in place to make sure they're able to continue directing this care? I always instruct and advise to have an exit plan in place. One thing we do know is as long as we're living, something's going to be going wrong with these old bodies, right? And so what's going to happen if client A now is no longer able to direct this task, right? Are we going to send them now to skilled, or are we going to bring in an RN to start delegating? Have an exit plan as part of that resident's care plan. Okay, now number 3 actually differentiates HMAs from RN delegation significantly, because number 3 said that the RN is not required to know the identity of the caregiver, right? Not required to determine the competency. That's definitely what the text says, right? I always encourage my clients to bring in the Texas Board of Nursing along with the TAC, and you want to go with the most restrictive requirement. That being said, as a nurse, I want to know that this family member is able to teach this caregiver, but I also want to know that this caregiver is able to apply the knowledge that is given to him or her, right? I want to know that they're able. If this caregiver has been called having 10 incident reports, 8 medication errors, I'm sorry, number 3, but as a professional nurse, I want to know who I'm allowing to perform these tasks, right? Number 4, the RN must assess a resident's status anytime there is a change in condition, physical or cognitive abilities, or the resident's condition changes at least once annually or every 6 months if the person has been diagnosed with Alzheimer's. All right. Then it goes on to say that if for some reason the RN comes in and says, no, this is not an HMA, next step of action is that RN can determine that the task is appropriate for RN delegation, right? And again, RN delegation kind of keeps the clinical liability on that nurse. And this was the area that I was trying to clarify with the state. And like I said, I'm waiting for a response. And maybe if anybody has an idea, we've got a lot of people from the state on here. Number 1 says D says, if the RN determines under section A1 of this section that an activity does not qualify as an HMA, not requiring delegation, personal care staff may perform that activity for the resident only. So this word only is getting me, only if the RN has determined in accordance with 22 TAC, chapter 225, that the activity can be delegated to the personal care staff member. And so the other word that's killing me here is and the activity constitutes the medication administration. So my question there is, it's saying only and then medication administration. So when I read this, it's saying to me that only medication administration can be delegated, which we of course know is not the case. So again, I've sent an email out. If anybody has anything that they want to offer with regards to that TAC, feel free to share it in the chat. And in fact, let's see, I don't know, Dominique, do we have any questions yet?
Not yet.
Okay, perfection. All right. So then I'm going to switch back to the PowerPoint once again. Any questions regarding CADDCT 553.263? Actually, is going to teach me how to say and document the actual verbiage for a reg one day. Any questions? If you got any questions, again, please go ahead and take this moment to put them in the chat. I'm going to go on. If that thing bounces, well, oh, it's not going to bounce, it's going to turn now. All right, what's excluded from HMAs? Again, we talked about this. We talked about this when we looked over, I think it's 225.4, but we will just circle back around to it briefly here. Nursing tasks. So again, assessment. An assessment cannot be a health maintenance activity. It cannot even be delegated, right? Only nurses and physicians, those with clinical licenses, can make assessments. Again, we did read when we reviewed that TAC that intermittent catheterization cannot be considered a HMA, and then insulin administration cannot be considered an HMA. And then, of course, remember, in order for a task to be considered an HMA, it must be for a condition that's considered stable and predictable, right? And so one of the things that I really found interesting in the regs is that, you know, let's say HMA is for, let's say, colostomy management, right? And the person gets a UTI, becomes very aggressive, has to go out to the hospital. And I don't know, maybe he's having a sitter now for his aggression. So his cognitive status has become non-predictable, unpredictable, as well as unstable. That does not take away from that HMA being appropriate, right? As long as the specific task or condition that the task is being performed remains stable and predictable, it can continue to be an HMA. Same thing if it's delegated, as long as the condition that the task is related to remains stable and predictable, delegation remains appropriate. Biggest thing for HMAs and exclusion when it comes to HMAs is if this task is being performed for a resident that does not have that support that TAC talked about, right? That the person themselves, they're not able or willing to direct, or that their loved one, again, is not able or willing to direct. The TAC goes on to say that they must be readily available, right? That they must teach and support. Most individuals in the long-term care environment, unfortunately, do not have that support. If that support is not in place, I just want to be very sure that you all understand then that task is not appropriate to be an HMA, and I encourage you to then seek out delegation. Oh, so creative. HMAs versus RN delegated tasks. So we kind of touched bases on this. Again, HMAs require written exemption from delegation by the nurse. So there needs to be documentation, not only saying this task is considered to be an HMA, we want that documentation to go ahead and detail why and who is supporting the performance of that task in place of that RN. Okay, HMAs do require the client or the responsible person's involvement, being available, supporting the staff, teaching the staff, directing that task is required for the task to be an HMA. Okay, HMAs do not require RN supervision. And so unlike delegated tasks, HMAs, if you guys remember, we said do not require that the RN actually meet or confirm that that caregiver is competent and able. Do I suggest that the RN does it? Absolutely. But the TAC does say, so you want to know what your regs say, but you also want to know what's safe. And as a nurse, if it's a nurse that's considering overseeing these kinds of tasks, you want to make sure that you are familiar with what the Board of Nursing says. That's our Bible, right? When in doubt, go with the most restrictive route. And then delegated task. Again, the delegated task does require RN assessments. And it requires that the nurse documents why he or she felt comfortable delegating these tasks to that specific caregiver, right? And so the RN in a RN delegation situation, their assessment needs to outline a couple of things. A, that the resident is stable and predictable. B, the caregiver's qualifications and competencies, right? And then any types of supervision. Of course, the supervision requirements for delegation are very vague, with the exception of insulin, right? And so if you go to the Board of Nursing and we start talking about insulin delegation, there are some specifics that are suggested when supervising the administration of insulin. Most important thing I'm going to say for delegation of insulin, review those blood sugars regularly. That is the only way to prove that it is stable and predictable. All right. Lastly, liability and legal considerations. Again, documentation. I suggest not only that you have your RN document those assessments we talked about and their supporting data, but I suggest having your RN review your caregiver's documentation regularly, right? I'll tell you, one of my clients, I was doing an audit and the caregivers were literally documenting like, Miss Sue was soaked when I got in this morning. Third shift always leaves her with 3 diapers on, and this isn't fair. Like, it's in the documentation. Remember, documentation is legal, right? At any given moment, this can go before a court. So I suggest if you are working with a nurse, which you have to be for HMAs or RN delegation, have them go ahead and review that documentation periodically and teach on documentation. One of the hardest things to do is get caregivers to recognize how to document objectively, right? But it can be done. And so I encourage you to utilize your nursing support systems for that. Clinical support, when you were thinking about legal and liability, okay, we've got this HMA, the nurses come in, signed off, you paid her for that quick assessment and documentation, and you'll pay her again in a couple of months when she comes by and does that next assessment. But who's got your back, right? Who's going to tell you, you know, a lot of times, especially when we start involving the family, we start getting some really creative things going. You know, they want to pour Coca-Cola and the tubes and do all kinds of things. And as operators or owners or even caregivers, you know, our primary concern is that resident safety and health. And so who do you call when something is not right? Maybe the condition has changed and you can't reach the family member. Maybe the family member is doing something that you know you all don't have orders for. So you want to consider having a clinical support anytime you go into HMAs or delegation. Lawsuits, right? Just recognize that if we are putting the clinical judgment and supervision into the hands of the family members or loved ones, chances of them suing themselves are slim to none. They are going to look for the person that is responsible. Normally, that's going to be the owner. With RN delegation, guess what? You've got a nurse with clinical background, with licensure, that can actually make clinical judgments and take some of that liability away from you and, you know, even support you in preparation for any type of legal implications. And then professional communication, right? I know that a lot of family members right now are Dr. Google. God bless Google, and curse Google as well, because we get a lot of creativity right now in the clinical realm. who is the professional who's able to decipher, again, what is clinically effective and safe, right? And so that is, again, another benefit of having that nurse or nurse practitioner or physician in your corner when it comes to liability. And I did not talk for an hour. Let's see, it's 11:42, and I am going to stop my screen share, and hopefully y'all can see me. I don't see any questions. Dominique, I don't know if you're able to unmute everybody. Participants, I think I might be able, no, not like that. All right, I'm gonna go ahead and unmute. And you guys feel free, questions, conversation. Hey, Candace. Cindy Sheehan.
Hi there.
Oh, thanks for jumping on.
Sure. I just wanted to clarify something. I think I misheard because I've been listening and not watching the whole time. When it comes to not being able to, was it not able to delegate insulin in an AL? Is that what you were saying?
Oh no, insulin can be delegated. It can't be determined to be an HMA. It can't be a health maintenance activity.
Right on, right there with you. I misheard. Thank you.
Absolutely, you're welcome. I don't know if you, with insulin, insulin is one of the only tasks that there are actually details on how it should be supervised. And are you familiar with that one?
Yeah, it requires additional supervision for the first month or so, several weeks.
Absolutely.
Yeah, before you can even determine, because that stability
it's key.
It can change so frequently. I love what you said, especially about people with, a dementia diagnosis, that you need to reassess. It's a good practice. Every year, too much can probably definitely need to reassess. Honestly, I would do it maybe even quarterly, because one of the things I tell my clients, and of course this is specific to PAS, is if you're going to be delegating, you also have to check in and see if something has changed with the caregiver, right?
Absolutely.
With the responsible party who is the one who's overseeing that care. Did they just set it and forget it and now life has changed? Have they moved out? Because if that situation changes, you may be, thrown back into delegation or more.
Absolutely. That's a good point. And so one of the reasons that our firm has grown is when you talk about caregiver, assessing the caregiver's turnover has been so high that one of the biggest reasons that we find that new clients come to us is the training and delegation turnover. So we've actually moved most of our trainings to our online platform. Caregivers can log in, take the class, test out, receive a temporary delegation under supervision, and then we're able to get a nurse out within 48 hours to actually do a return demonstration. Because keeping those caregivers, keeping up with who's there, so far as caregivers, is a task. Now, our clients are able to log into their portal, and they're supposed to report when someone moves out. They're supposed to report new referrals. But even with such a sophisticated system, we send our nurses out at least monthly. You would be surprised how many times we get out and we're like, oh, he's gone. We didn't know that.
So, well, and with HMAs, when the sister, say, is going to be the one who is managing all of the care for her brother and instructing your staff, what if her life changes?
Exactly.
Right? She feels like everything is set. She went off and got married, is no longer really involved. I mean, anything could happen,
Anything can happen.
She decided to go ahead and take full-time work because the agency is providing steady care now, but then she may not be available as much to direct that care. So yeah, all of those little factors that come into play need to be monitored regularly. So that's great. A monthly visit is better than most.
Absolutely. I'll tell you, I try to stay away from HMAs. I saw a need for this training because everybody's asking questions. And I
Mhm.
think that, from a professional perspective, I see that it could potentially save maybe some overhead cost by not having full delegation. But I don't think that it's worth the liability. And like you said, trying to keep up with the family member. Are they going to stay readily available? If they're not available, who's the backup plan? If this family member gets into a car accident, is there someone that can step in and fill his or her shoes? And so for that reason, I try to stay away from HMAs. I think I've done an HMA once, and that was the lady that was a nurse who literally lived at the bedside. She should have just moved into that community.
Right, right.
Yeah.
Yeah,
Yeah.
well, thank you very much for providing some clarification. I know that it's a pretty hot topic lately, RN delegation versus HMA, and some people try to push those bounds because they really want to be able to keep their residents, or they want to be able to keep their clients at home, but not just at home, but at home and safe, at home and
Yes.
cared for properly, you know.
Yes.
Yeah, well, thank you.
Absolutely.
This was a great class. I appreciate it.
You're very welcome. Thank you for joining. Thank you. I was so humbled and excited just seeing the different registrations. So thank you. Cindy, did you have a question? I see that you are off of mute.
Yes, I have a question, and it's regarding when we provide a service that is not an HMA. In the instance of insulin, and the person is able to, like maybe they have right side affected stroke, so obviously they can't use the right hand. So we inject the insulin wherever they would like us to. And you are talking about the LAR being able to, guide us with that. Do we need documentation from their, like in this case, his daughter is a doctor, a physician. Do I need some type of documentation from her saying that we can give her father his insulin as directed?
So that's a loaded question. So the first thing I want to clarify is insulin is one of the tests that cannot be considered an HMA.
Correct.
Okay. And so it requires RN delegation. And you're one of my clients. Yeah, I know exactly
Yeah,
who you're
you know,
talking. I don't know why you're
I'm
um
always about insulin. Well, I have so many, but
yeah. So in this situation, there's a couple of delegations that need to be in place. A is going to be that medication administration because the caregiver is injecting the insulin, medication delegation. I'm sorry, medication administration, diabetic care, right? So before we can give insulin, we need to know how to properly check blood sugars, what to do if there's a low blood sugar, who to call, so that's diabetic care delegation. And then thirdly would be that insulin delegation. And so that what should be documented is, of course, is all of the blood sugars, the delegation, and then if you remember that CRA signature form. So
yes.
this is a good point for everybody. Texas is definitely behind in the delegation realm. And so as I formed my company, I kind of looked into other states and then also into home and community-based services and what they were doing. There is a form, it's 85, is it 85? Let me see, I got it right here. It's 8584. Form 8584 is a comprehensive nursing assessment. I'll tell you, it's ridiculously large. I have revamped ours for our nurses, so it's not so long. But on page 16, there is a form called the CRA signature form. So what the Board of Nursing says that Texas Health and Human Services does not say is that there must be something in writing stating that LAR knows that these tasks are being performed by unlicensed assistive personnel under the supervision of an RN. And so I encourage you all to make sure you're getting that form signed if you are using delegation.
Okay.
Cindy, did that answer your question?
Yes, that did. Thank you.
You're welcome. Let's see, we got anybody else? Okay. am going to, Ashley, I don't know if you have any events coming up, anything that you wanted to announce. I appreciate you so much for jumping on as usual and supporting me. I will open the floor to you for any announcements, upcoming events, and to tell more about your company.
Right now, I do not have any upcoming events. I am working on several webinars and a new training series. So that'll go public eventually enough. I just am really appreciative of you allowing me to come in and support you. I'm very proud of you and the things that you are doing, and also opening up the conversation where other people have not felt comfortable in doing so. So I just want to make sure to champion your efforts and just make sure that people know that there are resources out here and you are one of them. So we are grateful to you for presenting today, and thank you for just allowing me to come and support you. I had the tag pulled up, I had my policy pulled up, and then I pulled up the board of nursing. So I was ready to answer questions, but you were on it. You were on it. So yeah. You're welcome.
Thank you so much. So Ashley knows the regs, life safety. She was a state surveyor, and so we kind of work together on a lot of projects. And she's probably being humble, but I speak things into existence. We recently touched bases and decided that we are going to try to fill the gap for these caregivers out there and do managers development and certification boot camp. It's going to be a 6-week program tentatively. And we're going to really help these care managers understand the operations, what the regs say, and care, right? What's the best way to care for these residents and why? Why do we need to turn them every 2 hours? Why do we need to get them out of bed? How long do we sit and wait for them to take their next bite? Why is it important to be on eye level with them? What do we need to look for in our building before a state surveyor comes? What can we do to make sure that we are compliant and survey ready at all times? And then we're going to be inviting the caregivers in as well. So I am really excited. I'm looking forward to working with Ashley to bring this together. It's another much needed training in our industry.
Yes, ma'am. Yes, ma'am. I'm looking forward to that compliance piece. You know, I love going in and helping those facilities have the compliance piece down and navigating and monitoring. So yes, that is upcoming. Thank you for mentioning that. I think I'm so excited for you. I forgot about that, but yes, ma'am, you were right.
Everybody needs Ashley to be that excited for them. All right, well, if there are no further questions, this concludes our webinar. Thank you all so much for joining me for this first webinar and being gentle with me. Look for upcoming webinars. And again, please share our dementia training, which is coming up on May 15th. It's going to be a 4-hour course. Great opportunity for caregivers. If you are an iNurse Delegate client, you will be receiving your unique code because of course there is no extra charge for you to attend. If you're not one of our clients, go ahead and visit our website, www.inursedelegate.com, and schedule a consultation. It's free, and it gives me a chance to learn about you and you to learn about us and how we can support you. Thanks again for joining. Y'all have a great Monday. Sun's coming out now. Bye.